Okay, I think we're live and welcome everybody. This is our monthly quiz, as you know, on the third Thursday of the month. We always will have a quiz, and the quiz will be roughly 10 questions. And I'm just checking my other thing that we are indeed live, so we are good. So let's get started. Hemoptysis, there's a lesion in the right lower lung, and when you look carefully at that lesion, it's enhancing. And if you look at it a little bit closer, it also looks like infiltrator hemorrhage in the right middle lobe, and maybe a little clot in both the left and right lower lung seen. But there is that enhancing lesion. And what is it? Well, on the coronal view here, you can see you can follow it to the pulmonary artery. So you then say, what is it? You have a pulmonary artery focally dilated. It's a pulmonary artery aneurysm. Now, pulmonary artery aneurysms can be due to many things. It could be due to trauma, prior procedure, tumors eroding into vessel, but there's also some vasculitis that can do it, and typically the one is Behçet's disease. So a really good case I showed yesterday in conference. We hardly ever see them. So there's a range of causes of pulmonary artery aneurysms and pseudoaneurysms, from pulmonary hypertension, prior trauma, infection, prior vascular procedures, and Behçet's is one of them. Nothing specific in those images for Behçet's, but a really, really nice case. Okay, another case, shortness of breath. Key thing here is this patient has a LVAD, patient has cardiac issues. You see very dense collapsed right lower lung, a little bit collapsed left lower lung. You'll notice that the study has no IV contrast. And then you look at the upper abdomen and you see the liver is of high attenuation. So now do you say, what gives you high attenuation lung, high attenuation liver? You can get high attenuation liver if you had recent IV contrast. We'll tell you the patient didn't. You could have things like thalassemia, copper disease, many things, but the one that gives you dense lung and dense liver classically is going to be, and remember I've already showed you this patient has cardiac issues, and this patient was on amiodarone. Amiodarone is the classic example, high density lung, high density liver. You can have amiodarone toxicity acute soon after you start the medication, and most of the time it's delayed. And when you start seeing dense lung or dense liver, the patient does have toxicity. And the problem is, even if you stop the medication, it's hard to reverse the toxicity. In this article by Gary Garamani, talking about high density material in the lungs, amiodarone is administered orally or intravenously, often for many years. Drug, excuse me, long half-life, and so it can be very problematic. Also, remember amiodarone, thyroid issues, interstitial fibrosis, high-density lungs, and liver issues. So a wonderful example of high-density liver due to amiodarone. Hemoptysis. When you look at the images quickly on this arterial phase, you see what looks like a mass near the right hilum, and then you look and you say, well, could this be nodes? Could this be a mass? But you got to say, could this be an aneurysm? And when you get later venous phase, you can see it's the same attenuation as the ascending aorta. And this was a large aneurysm, another wonderful example of a pulmonary artery aneurysm, really nicely shown on the cinematic rendering. Here it is with SVC shown to right atrium, and a really nice example from different perspectives of the patient's pulmonary artery aneurysm. Just a really nice example. And we don't see many of those. I was asking Satomi Kawamoto, who's one of my colleagues, and she had 5 of them over the last 30 years. So we will someday put a paper together on pulmonary artery aneurysms. Look at emergency radiology. That's where we're going to try to send it. Okay, great case. Incidental finding, vascular lesion in the liver, not as bright as the aorta, maybe a central scar. When I see this appearance, central scar and that vascularity, feeding vessel going to the center of the lesion, no neovascularity, I'm saying focal nodular hyperplasia. Obviously, you can think about hepatic adenoma, but the way the lesion looks, hepatic adenomas are not so homogeneous, don't have that central scar the same way. Now, typically with FNH, when you go to venous phase, the lesion is going to fill in relatively quickly, and you may see some mass effect or see nothing. This case was unusual because you can see the lesion, it's low density with the scar. Could it be hepatic adenoma? It could be, but I just don't like the way it enhances on the arterial phase. And this ended up being biopsied, but this was focal nodular hyperplasia and a atypical appearance. Another case, weight loss, fever. There's a big left adrenal mass, so my first thought is adrenal carcinoma, and there's liver lesions. Maybe the patient has an adrenal cortical carcinoma with liver mets. You look at there's also nodes in the portal caval space, but then we could flip it around, kind of like a Steinfeld episode, and say, well, maybe it's a hepatoma of the liver with adrenal mets and nodes. Remember, we make the point that metastases do come from hepatoma, often bilateral, and mets from hepatoma are often the largest lesions we see. And this ended up being a hepatoma metastatic to nodes, portal caval space, and metastatic to left adrenal gland. But if you stuck with a primary ACC and mets to the liver, it would be hard to argue with you. So just a really nice example of metastatic hepatoma to the contralateral or to the left adrenal gland. Another case, there's a mass in the body of the pancreas. There's really no dilated pancreatic duct. It's low density. Could it be an adenocarcinoma? It could be, but I would like to see a dilated duct. Could it be a mucinous cystic neoplasm? Great location, patient's right age, but this was a male, but it's still a possibility. More common in females, most common in junction of body and tail of pancreas. Could it be an IPMN with having dysplasia, which is why you don't see the wall sharply marginated? That's a thought. You can see it's somewhat exophytic, the way it's growing on the coronal views, and you have that soft tissue density there. So I got the feeling I'm really going to have to stick with mucinous cystic neoplasm. When you look at this case, and here it is on the cinematic rendering as well, you also need to always consider, could it be a neuroendocrine tumor? Now, I know we tell you neuroendocrine tumors are hypervascular, but sometimes they're hypovascular, sometimes they're cystic, sometimes they're like this case, which was a neuroendocrine tumor. So neuroendocrine tumors can be very misleading. Often with neuroendocrine, as in this case, you don't see duct dilatation. If this was an adenocarcinoma, you always would see, and always is a big word, but almost always see a dilated pancreatic duct, which you didn't see here. Back pain. Vascular lesion head of pancreas. You can see as you go through the multiple images, the vessels are draped over the lesion. It looks kind of cystic, looks kind of scar-like. There's no dilated common duct, there's no dilated pancreatic duct. The vessels are stretched, and maybe a better word is draped over the lesion. There's prominent vascularity, and this was one of those solid serous cystadenomas. Again, serous cystadenomas, we typically like to think about cystic lesions, but as we've said before, they often can have funny appearances, can be somewhat misleading. Often the cystic components are better seen on the venous phase. Now here's a great case. When you look at it quickly, the mass is coming from the stomach, and you say, just tumor, next case. You also can argue, could this be an adrenal tumor like an ACC? Lots of collateral vessels between the mass and the spleen. And you can see it's pushing the kidney over. Usually ACCs push the kidney down. You could also have considered a big exophytic renal mass or lymphoma. I showed a case a couple weeks ago like that. But this mass is large, central necrosis, abutting the stomach, and it's hard to totally exclude a GIST tumor. But this mass, believe it or not, came from the pancreas. Look how necrotic it is. Look how much neovascularity there is, even extending into the venous phase. And this is a case you might have a better time diagnosing if I said the patient was 5 and not 55. This was a pancreaticoblastoma in adult. Looked like a GIST tumor, looked like some neuroendocrine tumor perhaps, maybe throw in that ACC, but just a wonderful, difficult case. We do not see many pancreaticoblastomas, I will say. Average age about 5. They're large lesions, so but usually it's in young children. Abdominal distension, and yes, when you look, you see implants on the omentum, the mesentery, on the stomach, and throughout the retroperitoneum. First thing you're going to end up saying with scallop lesions, this is carcinomatosis, pseudomyxoma peritonei. Could it be from appendix, from ovary, from stomach, from bile duct or pancreas or anything else, colon? Well, that's a good thought. You can see some of the lesions are calcified, which push you to mucinous. Again, I would be thinking ovary with the right history, but the patient had no history and there's a mass in the pelvis. Maybe it's just ovarian cancer with carcinomatosis. This was biopsied several times and path done, and this was not metastatic like in the pseudomyxoma peritonei from an appendiceal tumor or ovarian tumor or gastric tumor. This was a primary peritoneal mesothelioma. It's rare, it's infiltrating, looks just like pseudomyxoma peritonei, but there's no primary tumor and kind of a difficult case. FUO, splenic infarcts, right renal infarcts, and an enhancing lesion in the patient's liver. Is this another site of infarction or abscess? What is going on here? When you look around, the bright enhancement is really enhancing like a vessel. It's not enhancing like the liver. And you can see when you get later, it kind of disappears. So what are we dealing with? A very bright structure, which looks just as bright as the hepatic artery. And then when you look through the MIP imaging, you can see it connects to the hepatic artery. It's a wonderful vascular structure. And what are you thinking about with the vascular structure in the liver? You're thinking about an aneurysm or pseudoaneurysm. This ended up being in a patient with endocarditis. That explains the renal infarcts on the right, the splenic infarcts, and the mycotic aneurysm. Just a really, really great case. And I think that's 10 cases, and those are 10 terrific cases. Yesterday we discussed them. The guys, my colleagues, not the guys, did really well answering the questions and teaching the residents and fellows. But hope you like the cases as well, and hope to see you next time. Catch you later, everybody.